Hello viewers, I am Dr. Phani Krishna Ravula. I am a surgical gastroenterologist and an advanced laparoscopic surgeon. Today we'll be talking about obesity and its treatment. Question 1. What is bariatric surgery? How does it work? The term bariatric surgery basically means surgery for obesity. Nowadays we don't use the term bariatric surgery anymore. We mostly call it metabolic surgery. The reason why we call it metabolic surgery is basically the mechanism by which this surgery works. So bariatric surgery, you can look at it as two categories of surgeries. There are restrictive surgeries. Restrictive surgeries means surgeries which reduce the size of your stomach. And then there are malabsorptive surgeries, which these malabsorptive procedures, they don't just restrict the size of your stomach, they also decrease the amount of fat and calories that are getting absorbed. So these are called malabsorptive procedures. These two procedures, restrictive and malabsorptive procedures, cause some changes in your basic gut hormones. So the body, there are gut hormones which actually regulate several aspects of your metabolism, like your basal metabolic rate, your hunger, the feeling of satiety, the feeling of fullness that you get, then the energy metabolism, the glucose homeostasis which controls your diabetes, and then the fat deposition. So all these energy metabolism related factors are regulated by certain hormones, and these gut hormones levels are positively impacted by this bariatric surgery, which leads to a long-term effect on your health, not just in terms of obesity but other obesity related complications such as high cholesterol, your diabetes, and cardiovascular risk, and so on and so forth. So that is what bariatric surgery is. Very often people confuse bariatric surgery with something called liposuction. Liposuction is basically a cosmetic procedure. Cosmetic surgeons, they do liposuction in an area of your tummy where you have fat. They put needles in and suck out that fat. It's a very temporary cosmetic local effect which occurs. While bariatric or metabolic surgery alters your body's hormonal profile, alters your metabolism to have a long-lasting impact on your not just your obesity but your overall health as well. Question 2. Who needs bariatric surgery? Do I qualify for bariatric surgery? The indication for bariatric surgery is in a particular group of patients with severe obesity and obesity-related complications. So, how do we objectively measure who needs bariatric surgery? We use a simple parameter called BMI, body mass index. So, this body mass index is a parameter which is calculated based on your weight and height. So, body mass index more than 25 is overweight, more than 30 is obese, and when your body mass index crosses more than 32.5 with obesity related comorbidities. Obesity related comorbidities means obesity related problems. The common obesity related problems are diabetes, hypertension, fatty liver, then the obstructive sleep apnea, heavy snoring and obstructive sleep apnea, breathing difficulties, knee pains, high cholesterol. So when you have these kind of obese 32.5 BMI with these obesity related complications, or 37.5 BMI, even once you are 37.5, even if you don't have these obesity related complications, you qualify for bariatric surgery. So in addition, in Indian males, the central obesity, especially the males, the central obesity is a very big problem. So irrespective of your BMI, if your waist circumference is more than 100 centimeters, even then you qualify for bariatric surgery. And particularly in patients with type 2 diabetes, if you have uncontrolled sugars with very poor sugar control and high insulin requirement. So the problem when you have very poor sugar control and high insulin requirement is that over a period of 10-15 years, you're going to inevitably end up with kidney failure, heart problems, nerve problems, and leg ulcers and all those problems. So in patients with uncontrolled diabetes, if your BMI is more than 27.5, also the diabetic associations recommend that bariatric surgery is required. So essentially, bariatric surgery we do for patients with morbid obesity, BMI more than 37.5 or BMI more than 32.5 with obesity related comorbidities, or in patients with uncontrolled diabetes with BMI more than 27.5. So why do we call these BMIs morbidly obese? there are three reasons for that. One is, once you are a morbidly obese person, let's say you at 35 you're a morbidly obese person and a person of your same age who is of a normal weight. Compared to the normal weight person, a morbidly obese person, the life expectancy, the lifespan is reduced by 10 to 15 years. The reason why this happens is again because of these problems, the morbidly obesity contributing to your uncontrolled diabetes, your hypertension, risk of coronary artery disease, risk of stroke, respiratory problems, liver problems, all those issues. So because of all these problems, cancer risk, because of all these problems, the life expectancy is reduced, and at that particular BMI, 32.5 with obesity-related problems or 37.5 by the morbidly obese definition, because of these obesity-related serious health hazards, your life expectancy is shortened. So at this point, obesity becomes a serious health problem and it's called morbid obesity. So these patients, you need bariatric surgery. The other impact the morbid obesity has on the quality of life. How does morbid obesity affect your quality of life is basically once you're a morbidly obese person, the way you go about your life, the way you enjoy your life, the way you live your life is affected. Because if you have breathing problems, you can't walk fast, you can't climb stairs, you can't fit into narrow chairs. There are the self-esteem issues, the social issues of people mocking and finding a life partner and those kind of issues. And then you have issues like in the long run, knee problems, knee pain, back pain, and all those problems. Obstructive sleep apnea affects the quality of sleep, and many times these obese patients, they have, they keep going to sleep in the mornings, narcolepsy they call it. And so all these, for minor infections, as the obesity gets as the age advances, even patients with obstructive sleep apnea, your heart is, the right side of your heart becomes very weak. So even minor hospital problems, you have to keep getting admitted into the hospital. So in addition to the quantity of life, the life expectancy, morbid obese patients have a significantly poorer quality of life, and therefore these patients need bariatric surgery. The third major significance of morbidly obese is that it is scientifically proven that patients with morbid obesity cannot lose weight by diet and exercise alone. This is because everyone has a metabolic set point. So you have patients, young patients or older patients who eat a lot of food and they remain like reed thin, very thin for their entire lifetime. And then you have patients, a lot of obese patients who say that, doc, I don't really eat much. I eat normal quantities of food, but I keep on putting on weight. Why does this happen? This is because of your body's metabolic set point. The metabolic set point, your basal metabolic rate is different in different individuals. So the patients with endomorphic appetite, the first group of thin patients are called ectomorphs. Whatever they eat, they remain thin. While these obese patients, they are called endomorphs. So these endomorphs, because the metabolic set point is adjusted, altered, even if they eat less, they don't tend to lose weight. So it's not as simple as eat less and exercise more. Once you reach a certain degree of obesity, like 37.5, you may do your exercises, you may do your keto diets, you may do intermittent fasting and all that, and temporarily you may have some weight loss of 10-15 kilos, you may have temporary weight loss, but because your metabolic set point is readjusted, you tend to regain weight. So it is proven after a lot of research that patients in this morbidly obese group, the sustained weight loss is not possible in them by diet and exercise alone. So for these three main reasons, one is the life expectancy is short, number two is that the quality of life is significantly impaired, and number three is that these morbidly obese patients don't have sustained weight loss with your traditional diet and exercise because the major component, the basal metabolic rate set point, is altered in these patients. For this reasons, the patients with morbid obesity, BMI more than 35, 32.5 and BMI more than 37.5 and 32.5 with comorbidities, in these patients, bariatric surgery is indicated. Question 3 is, does insurance cover bariatric surgery? So once upon a time, insurance would not cover bariatric surgery. It used to be a big problem because they used to label it as cosmetic surgery. But now, both we and the Supreme Court and the insurance companies, everyone recognize that bariatric surgery is not a mere cosmetic surgery. As we have discussed in the previous segments, bariatric surgery basically alters your metabolic and hormonal profile to have multiple positive impacts on your health, like not just obesity, your diabetes, your heart disease, your stroke risk, your cancer risk, and your liver health, your kidney health. So it has a lot of positive health and positive health impacts, and it is not considered a cosmetic surgery anymore. So especially since last year after Supreme Court order, every insurance company should provide bariatric surgery cover. They have specific criteria. These criteria are based on the Western model. So basically, anyone with BMI of 40 and anyone with a BMI of more than 35 with obesity-related comorbidities, especially diabetes, obstructive sleep apnea, NASH, fatty liver and NASH, with these kind of obesity-related complications, they are eligible for insurance coverage. And the entire surgery, post-op stay, their consumables used, everything can be covered under insurance. Since the past 1 year, we've been doing it on a regular basis. Is bariatric surgery safe? Bariatric surgery or surgery done for obesity is generally considered a very, very safe surgery. The incidence of direct surgery related complications such as anastomotic leaks. Anastomotic leak meaning where we cut the stomach or join the stomach to the intestine, the suture line leaks and then you have infection in the abdomen leading to problems. So these kind of complications are less than 1 in 200. With the advanced technology we have like stapling devices and reinforcing devices, the leaks are very low. Direct other complications such as cardiac complications, respiratory complications, DVT. These are the three most common problems the patients can encounter after any major surgery, especially the obese patients. Cardiac, then respiratory, and DVT, that is blood clots forming in the lungs and going to the lung. Blood clots forming in the legs and going into the lungs. So these kind of problems can occur post-surgery. Obviously, patients who are obese are at a slightly higher risk for these complications compared to a person with a normal weight. But these kind of complications can be avoided by doing a thorough preoperative evaluation by a cardiologist, pulmonologist, assessing the DVT risk score and giving them better perioperative care like giving them anticoagulation, giving them DVT stockings which actually compress the lower limbs and prevent the blood clots from forming. Very well coordinated surgical team which can finish the procedure effectively, and a good post-operative care by mobilizing the patient quickly and actively. So with all this, despite these patients, the obese patients being at a higher risk of complications compared to the general population, the incidence of these cardiac, respiratory and DVT complications is still very, very low. Essentially, it boils down to any procedure. There's no such procedure with zero risk, but when you look at a surgery like bariatric surgery, you have to weigh the risks and the benefits. The risks obviously are because the obese patient, diabetes, there's a risk of cardiac, respiratory and DVT kind of problems. While the benefits are of obviously the long-term cure of diabetes, hypertension, weight loss, reduction in risk of heart attack, stroke, reduction in risk of cancer. So we in any medical decision, we need to actually balance the risk, and most of the time in these patients, the benefits far outweigh the risks. There's another confusion among a lot of general public about some Bollywood actresses who succumb to sort of bariatric surgery. That is not true. A couple of famous actresses, I would not take the names, but who have actually died secondary to a procedure called liposuction. I mean, liposuction again is a fairly safe procedure done by plastic surgeons. It is basically doesn't alter your metabolic in any way, doesn't alter your glycemic sugar control, doesn't alter your cardiac risk or anything in any way. It is just in one particular part of the body, like your abdomen or in your buttocks. If you have excess fat, it is sucked out through needles. So when they do it on the abdominal, when abdominal liposuction, repeated surgeries are done, the abdomen becomes scarred and the bowel gets stuck to the abdomen. And when they're doing this liposuction, the bowel can get injured. So the couple of famous cases are actually secondary to abdominal wall injury and bowel injury sustained due to repeated liposuction. So to summarize, bariatric surgery is a very safe surgery done in experts' hands with a good perioperative team, the anesthesia, the post-operative respiratory care team, if they're very good, with a good surgeon. It's a very safe surgery. We have to take the necessary precautions, necessary preoperative evaluation. But essentially, these patients are slightly higher risk compared to general population. But most of the time, the benefits of surgery outweigh the risks. Does bariatric surgery control diabetes? Yes, bariatric surgery controls diabetes. Bariatric procedures such as sleeve gastrectomy, Roux-en-Y gastric bypass and mini gastric bypass have been shown in literature to completely reverse diabetes in 60 to 80% of the patients. Of course, the Roux-en-Y gastric bypass and mini gastric bypass procedures are slightly more effective compared to sleeve in reversal of diabetes. How does this reversal of diabetes happen in bariatric surgery? So it's by three mechanisms. The one mechanism is obviously the weight loss, because the type 2 diabetes is related to obesity and insulin resistance. So the weight loss leads to diabetic control. The number two is because the stomach size is small, you're eating small portions, and because these eating small portions and controlling your diet, the diabetes becomes controlled. But the third and the most important way diabetes gets controlled is by metabolic phenomenon. So when you do bariatric surgery, you see that the incretins, there are some hormones in the body called incretins. Incretins means you have peptide YY, GLP-1, and these kind of lot of incretins are there, which sensitize the body to insulin. So basically in diabetes, you have an insulin resistance. Type 2 diabetes, you have insulin resistance. So the insulin regulates the glycemic sugar control as well as the fat deposition. So once this is impaired, these patients have type 2 diabetes. But once we do bariatric surgery, we actually, most of the patients, the day we do bariatric surgery, from next day itself, we can stop the sugar diabetic medication. The reason is, the moment we do the bariatric surgery, the incretin levels go up, they sensitize the body to insulin, and because of that, the sugar controls becomes better and the sugar gets controlled. So that is the most important mechanism. Do all the patients who undergo bariatric surgery have sugar control? That question needs further deliberation. So basically, bariatric surgery helps control type 2 diabetes. If you have type 1 diabetes, it is never going to be reversed by bariatric surgery. The current recommendations are that if you have a BMI of more than 32.5 with diabetes, or if you have even if you have a BMI of 27.5 with uncontrolled sugars, with a high HbA1c of more than 8 and uncontrolled sugars despite being on insulin or and oral hypoglycemic agents, these two patients, BMI more than 32.5 and with diabetes, and BMI more than 27.5 with uncontrolled diabetes, these two patients, you can of type 2 diabetes, the diabetes gets reversed in 60 to 80% of the patients who undergo bariatric surgery. Why does it not get reversed in all? Basically, the mechanism is, in type 2 diabetes, normally there's insulin resistance, so the insulin production is high, but the insulin is not working because there is, at the end organ level, there is insulin resistance. When we do the bariatric surgery, what happens is the incretins sensitize and increase the end organ response to the circulating insulin, and because of which the sugar control occurs. But in some type 2 diabetes, over a period of years, there is some amount of pancreatic failure as well. That means the insulin C-peptide levels are coming down. So in those kind of patients, you may not have reversal of diabetes. So how do you predict this? We basically, before the surgery, we do some tests to rule out type 1 diabetes. We look at the fasting and postprandial insulin and C-peptide levels. If the fasting and postprandial insulin and C-peptide levels are normal or elevated, in that case, your diabetes is going to get controlled or reversed by the bariatric surgery. In case your fasting and postprandial C-peptide levels are low normal or very low, in those kind of patients, you may not have a complete reversal of diabetes after bariatric surgery. But even in these patients where complete reversal of diabetes is not possible, uncontrolled diabetes becomes controllable. Patients who are on insulin can be taken off insulin, and patients who are on 2-3 sugar medication, anti-diabetic medication can be reduced to one medication. So in all the patients with type 2 diabetes, the bariatric surgery either completely reverses the diabetes or makes it much easier and brings down the sugars and makes it much easier to control the diabetes. What are the types of bariatric surgery? Bariatric surgeries can be essentially classified into two varieties. Basically, you have restrictive procedures and malabsorptive procedures. Restrictive procedures, basically, you have procedures like sleeve gastrectomy and a laparoscopic band applied. So, and of course, nowadays we are doing the endoscopic sleeve gastrectomy in patients who are not fit or willing for regular sleeve gastrectomy, which leads to about 10 to 15% of weight loss. In these restrictive procedures, by whatever way, by laparoscopy or putting the band, we are actually reducing the size of the stomach into a 30 to 50 ml pouch. Because the stomach is a 30 to 50 ml pouch, the fundus of the stomach, which produces the ghrelin, which is the hunger hormone, that levels are reduced, as well as because of the small size of the stomach, the food capacity is reduced. The food eating capacity is reduced, early satiety occurs, and because of the intake is reduced, and also the hunger is reduced because of the ghrelin, and because the food is getting emptied rapidly into the intestine, the incretins, the peptide YY, GLP, those hormone levels are also improved, helping in glycemic control and regulating the fat deposition. So that's how the restrictive surgeries work, be it sleeve gastrectomy, lap band, or endoscopic sleeve gastrectomy. Then you have the malabsorptive surgeries. In these surgeries, basically we make the stomach into a small pouch, into a 30 to sometimes not 50, so 30 to 60 ml pouch, and also bypass some intestine. Like about it can vary from 100 to 200 centimeters of intestine is bypassed, so that the patient not just eats less, but also because some of the intestine is bypassed, they absorb less, so the food absorption is also less. So this is basically the gastric bypass surgeries. You have the most popular include the Roux-en-Y gastric bypass, then the mini gastric bypass. There are other more complex bypass surgeries for super obese. We don't need to discuss them now, but essentially the commonest bypass surgeries we do are the Roux-en-Y gastric bypass and the mini gastric bypass. So the difference between sleeve and one type of surgery is the restrictive like sleeve, and malabsorptive like bypasses. The malabsorptive surgeries like gastric bypass, RYGP, are more powerful surgeries. So in sleeve, the weight loss stabilizes by 8 months, and after 2 years there is some chance of weight regain if the patient doesn't follow a very disciplined diet and lifestyle. But with the malabsorptive surgeries, the weight loss is generally, once it goes down, it never goes up unless the patient is consuming a lot of alcohol, a lot of sweets. Most of the time, even if the patient doesn't follow a very strict exercise and dietary regimen, the weight regain is not much. The disadvantage of so any more powerful surgery, better weight loss, more durable weight loss. But the disadvantage of malabsorptive surgery is because some amount of intestine is bypassed, some important nutrients are not very well absorbed. So patients who have had a bypass, depending on what level of bypass, they would require additional iron, calcium, protein supplements. These are especially important in the first 5 years post bariatric surgery, but preferably should be taken long term also. So both surgeries have their pros and cons. Sleeve, effective but less effective surgery, and results tend to plateau after 2 years. Gastric bypass, more powerful, more effective surgery, but more risk of nutrition deficiencies. The patient needs protein and iron and calcium and sometimes vitamin B12 supplements. What are the side effects of bariatric surgery? So any procedure that has an effect has side effects. So for example, of course, obesity is a $600 billion industry worldwide with a lot of gimmick medicines, a lot of sort of capsules from the rainforest and magic pills which are offered in the market, which have claimed to have no side effects, but they have no effect as well. So when you do a powerful surgery which is going to alter your body's metabolism and make you lose weight, it is going to bound to have some side effects. We should see the important thing is not having side effects, but how difficult are these side effects. So something like surgery like sleeve gastrectomy, the basic bariatric surgery we do, the side effects it has are usually only in the first 1 month. First 1 month, the kind of side effects you have is basically a bit of, sometimes when you eat food, you have choking sensation, you have a bit of nausea, you have vomiting. These kind of symptoms may be common in about 30% of the patients in the first 1 month. But after the first 1 month, usually these symptoms are resolved and most of these patients have no side effects. One more problem with sleeve is if patients having reflux symptoms, acid reflux symptoms before the surgery, these symptoms can be worsened after the sleeve gastrectomy. So it's very important for the treating doctor, gastroenterologist who's doing the bariatric surgery, he should actually assess for reflux, and if you have reflux, he should tailor the bariatric surgery accordingly. We either do a Roux-en-Y gastric bypass or a mini gastric bypass and repair the hiatus hernia. If not, that symptom of GERD, gastroesophageal reflux disease, can get worsened after sleeve gastrectomy. When you look at the more powerful surgeries such as gastric bypass and Roux-en-Y gastric bypass, in these surgeries also, in the first couple of months, you may have similar problems like sometimes choking on food, a sensation of heaviness in the chest, because the stomach is now made into a very small pouch. You can have feeling of nausea, sometimes retching, and sometimes choking of food. But these symptoms almost always subside within the first 1 month. So these surgeries being more powerful surgeries, because there is some component of intestine being bypassed, there's some degree of malabsorption. You need to make sure that you have adequate supply of nutrients, supplementation of nutrition such as iron, calcium, vitamin B12, and also protein nutrition, so protein energy. So if proteins are not taken, you can lose weight after surgery, but along with your fat, you lose the muscle mass also. So you become thin, but you're not healthy. You're skinny fat. So because of that, after these surgeries, we need to maintain the iron, calcium, vitamin B12 supplements. Also make sure that the patient has adequate protein intake so as to avoid protein allergy malnutrition. So the side effects of bariatric surgery, to summarize, are very minimal, especially after sleeve. Some lifestyle adjustments are required, like for example, you go to a party or a meeting, or sit down with lunch with your friends. Each one of them is having like 4 idlis, but after only a single idli you may get full. So it's slightly socially embarrassing, but those are minor adjustments you have to make to achieve adequate weight loss and have benefits which last for the rest of your life, like reversal of all the obesity related problems. So with these, other than these kind of minor problems, with sleeve and minor nausea, vomiting in the first one, no other side effects. With the mini gastric bypass, these are more powerful surgeries, so you need to be followed up with a good nutritionist and a good gastroenterologist who's going to monitor your post-operative outcomes, monitor you for protein energy malnutrition, monitor you for vitamin and mineral deficiencies. But with adequate supplementation of nutrients and adequate protein supplementation, all these side effects can be easily avoided. Another side effect you may see after mini gastric bypass is increased stool frequency because of the bypassed intestine. You might pass 2 to 3 stools a day rather than 1 stool per day. But all these things get corrected between first 5-6 months. What do we do for laxity of skin folds after bariatric surgery? So after bariatric surgery, it is very common, especially if you're in the elderly age group with a lot of loss of skin elasticity, or if you're super obese, BMI more than 50, more than 50 and more than 60. We see patients with 65, 70 BMI also. For those kind of really obese patients, you can get saggy skin. So after losing a lot of weight loss, you can get a lot of saggy skin in your chest, saggy skin especially of your belly fat, saggy skin at in the arms, and saggy skin at the buttocks. So in these kind of patients where you have a lot of saggy skin, obviously once the adequate weight loss is achieved about 1 year after the surgery, if you are cosmetically, it looks poor, by a very simple surgery is called tummy tuck, in which the entire extra skin is excised through hidden incisions you can't see. This extra skin can be removed and you can have a very good cosmetic result.